So the next topic is we're going to move on to the midfoot. So midfoot composed of medial cuneiform, middle cuneiform, and lateral cuneiform, navicula, and cuboid. So the first one we call accessory navicula is the extra bone that forming at the inner part of the foot. So the accessory navicula is its normal variant. We can see in around 12 to 18% of the normal population. So majority of the patient are asymptomatic. They have no pain. Sometimes they can see the bulky bony protrusion on the inner part of the foot. And most of the patients are female. It occurs at the plantar medial enlargement of the navicular bone. And the accessory bone can be excised, or sometimes it can be completely ossified with the main navicula. It can be transmitted to genetics by autosomal dominance, and associate a problem that we commonly see is a flat foot deformity and posterior tibial tendon dysfunction. There are three common classifications for the accessory navicula. The first one, you can see the small ossicle that can see on the left hand side and here on the x-ray. So the sesamoid bone is located in the tibialis posterior tendons. The next type we call type 2. This is bigger of the ossicle or the sesamoid compared to the first one you can see on the right hand side in the middle picture. It usually connects to the main navicula by cartilage. We call synchondrosis. And the last type is the bony completely ossifications and connect to the main part with the bony unions. So you can see here. When we look into the detail, so we can see they have type 1 and they also have type 2A and 2B and then type 3. Okay. So normally when we look into the navicular bone first, it's a single center of ossification. It usually ossify. It means calcium deposit grow in 3 years old and boy in 5 years old, and we fuse completely at 13 years old. But when we look into the accessory navicula, so it usually occur and it's gonna be fused, but not early than age 8 years old. The problem that's happened because it's failure to fuse with the main navicula. So it can be present when the patient grow up and cause the pain. So once you estimate the diagnosis of the accessory navicula by using a physical examination to see the prominence on the inner part of the foot and x-ray show the accessory navicula. The treatment should be consisted of conservative management, including rest. Try to use the foot as less as possible. No running, no jumping, no contact activity. Sometimes you may need to put the patient in a short leg cast for a couple weeks to help for the decreased inflammation. You may need to modify the shoe that's not rub on the bone. And then medication, especially anti-inflammatory medication, will be helpful. And as you know, it's associated with the flat foot deformity. So arch support is important. That can be helpful as well. However, if the conservative management fails, so surgical treatment is indicated. You can do either one of these by performing excisions or fusion of the accessory navicula. It depends on the size of the accessory navicula. So they have many studies to prove there was no significant difference between the two techniques. For excision, you can take it off as shown on the right hand up above pictures. And you also need to treatment the inflammation of the tibialis posterior tendon and then reroute or reattachment of the tib post on the main part of navicula. For fusion, we usually take down the cartilage between the accessory navicula and also at the navicula, and then perform the fixation by using a screw.